further ado, I want to introduce you to Bobby Peterson. And then at the table here, we have our ship counselors, Malcolm, Laura, Amanda, and Elizabeth. Give them a good warm welcome.
Can you hear me, folks? Everybody hear me? Awesome. I really appreciate you guys having me out today. I really enjoy doing stuff like this because I call myself a double unemployment major. I rarely get to use my degree when I work, but I'm a vocal performance and theater major. And so I sing opera, but when I get to come out, I actually get to speak in front of folks, and so I get to interact with the crowd, and I really enjoy that aspect of what I do. So I appreciate the time today for sure. Like Ms. Teresa said, we will take some questions afterwards, and I'll kind of truck along through everything. And I will stick around afterwards as well. If anybody has any specific questions, I will be happy after the question and answer session to answer more questions. So, with further ado, let's dive right in. A bit of an agenda. So I like to approach Medicare by breaking it down into its foundational parts. As I'm sure all of you are aware, if you've been on Medicare for a little bit, or you're starting to study it to become, Medicare eligible coming up, there's a whole alphabet with the letters. There are tons and tons and tons of intricacies and things that change from year to year. And so the easiest way to kind of eat the whole elephant, right, is to take a bite at a time. And so let's break it down to its foundational aspects, understand those, and then expound upon it. So we'll talk about what Medicare is just in general, Medicare, original Medicare proper. We'll talk about who's eligible. Then we'll break it down into the parts of Medicare. When I say part, those are actual parts of Medicare. So we'll talk about what the difference in parts and plans are later. But A and B, which is original Medicare. Part D, which is the dreaded prescription drug plans. We'll talk about penalties because when I leave the stage today, no one in here is going to have a penalty. That's the bane of my existence when I find people that have unfortunately found themselves in penalty situations. So we're going to do some question and answer, some call and response, so we all remember with a pneumatic device that we're not going to get penalties. We'll talk about Part C, which you won't hear me say a lot. Those are Advantage plans. I think there's enough letters. We'll talk about supplements, and then we'll talk about how to sign up for Medicare and how to choose your coverage. So just in general, what is Medicare, right? So Medicare is a federally funded health insurance program, and it's overseen by the Center for Medicare and Medicaid Services, which is an offshoot of the Department of Health and Human Services. One thing about Medicare that is different than what most of you are used to when you have group or marketplace or private insurance is that Medicare A and Medicare B are standardized nationally. So someone in Nome, Alaska, and someone in Tallahassee, Florida, and someone in between, all of their Medicare A and B are going to be identical. So there's not a better one or a worse one, and you can't purchase a better one or spend down to have a lesser version of Medicare. Folks that are eligible for Medicare, typically people remember that around 65, at age 65, you can enroll into Medicare if you've worked 40 quarters, which is 10 years, or have a spouse that has. But there are also folks that are eligible for Medicare who are under 65. And if you've been on disability for up to 24 months, the 25th month, you were actually eligible for Medicare. And then some chronic illnesses, like ESRD, end-stage renal disease, if you're having kidney failure, or ALS, which is Lou Gehrig's disease, will allow you to have Medicare prior to 65. So Medicare Part A, right? This is original Part A Medicare. Typically speaking, it doesn't cost anything. Now there is a premium for it if you haven't worked your 10 your 10 years or 40 quarters, and you can purchase Medicare Part A. There's also a lessened premium of $238 per month if you've worked 30 quarters or less. But typically speaking, most folks have Part A and no cost. Now, who here knows what a deductible is? You've probably seen deductible on your group insurance or your marketplace insurance, private insurance. A deductible is a portion of money that you have to satisfy before your insurance starts covering. So you're responsible for paying that before the insurance begins giving you benefit. Okay? Most folks are also used to a deductible being annual, right? So it comes and it rears its head once a year, its ugly head, and then it goes away in January. Now Medicare Part A is a little bit different. Medicare Part A has a $1,600 deductible. However, it's a 60-day recurring deductible. So for example, in January, let's say you go and you spend the night, at least one night in the hospital. You'll satisfy the $1,600 deductible, and then let's say that you take 60 days off from the hospital, and then you have to go back, let's say in January or in June. In June, you'd have to do it again. And then let's say you had to go back in November, you'd have to do it again. So that recurs and can be a large gap. When you talk about gaps in insurance, gaps are financial responsibilities that you have to deal with as opposed to the insurance company. Okay? So as we talk about gaps as we walk through this conversation today, just remember, those are things that you will be responsible for financially as opposed to the insurance company. Who here knows the difference between copay and co-insurance? So a copay is a set amount. You may recognize that when you go see your primary care physician or your specialist. You always pay $25, or you always pay $50, and you know it's going to be that every time you go. A co-insurance is what you often may see after your deductible. Like on lots of group insurances, you'll see the deductible for procedures or hospitalizations, and then a percentage after that, right? 30% or 20%. So that is a co-insurance, and it is a percentage of the entire charge. So, for example, let's say you went to your primary care physician, and you had a 20% responsibility, and it was a $100 bill at the end of the day. The insurance would pay $80, you would pay $20. Let's say that you went to the specialist, and it was going to be $100, but after he listened to your heart, he says, well, let's do an EKG, and let's also do a stress test, and maybe some blood work. Well, now that $100 is maybe $1,000. So an 80-20 split is now $800 for the insurance company and $200 for you. Take it a next step. Let's say that you had a knee replacement surgery. Well, that may be a $20,000 surgery. And so 80%, 20% now, as you can see, is grown and grown and grown. So that can be a very small gap, but it also could end up being a large gap. In relation to Medicare Part A, your first 60 days after the deductible are at no cost. So if you continue to have to stay in the hospital and get treatment, your first 60 days won't have any copay or co-insurance after your deductible. But here comes some large gaps. Days 61 through 90 are $400 per day. And then day 91 and beyond are $800 per day. So as you can imagine, you're going to have to be in a pretty serious healthcare situation to be in the hospital that long. But should you find yourself in that situation, it can be very costly. So those are very large gaps. Let's talk about a few things Medicare Part A covers. Think about Medicare Part A as the renting space almost. It's not really the doctors at the hospital, it's being at the hospital or being in a facility. But the surgery center, the blood while you're in the hospital, hospital stays, of course, we've already talked about, skilled nursing facility care, home health care service, and this is an interesting one. When you've been in the hospital or a skilled nursing facility for less than 100 days, Medicare Part A picks up home health care services. The other way around is Part B. And then hospice care. So hospice care is if you're determined as terminally ill, comfort as opposed to treatment, and it's typically provided in the home, sometimes in a nursing facility. But it's important to remember hospice care because regardless of, we'll talk about different pathways in the future and different types of plans that you can choose, but hospice care will always be taken care of by Medicare as opposed to an Advantage plan or anything else, a Medicare supplement. Medicare always handles the hospice care. Medicare Part B. Part B is medical insurance, so that's your outpatient care, your doctors, and your specialists. So your monthly premiums are going to be based upon income, depending upon that if that is higher or lower. The standard Part B premium this year was $164.90. Next year, that is going to go up to $174.80. It doesn't always go up. This past year, it did come down from $173.10 from the year before this, but it is going up again next year, so be mindful of that. Depending upon your income from 2 years prior, you may fall into what is called an IRMA category. IRMA stands for Income-Related Monthly Adjustment Amount. And so however you may have filed in 23, so back into 21, or in 24 and 22, depending upon your income levels, you may pay a higher premium than the standard Part B premium. If that is something that you want to ask questions or talk more about, I do have some charts that we can share later with that. But that's something that is important to be aware of. You also may not have to pay your Part B premium. There are what are called Medicare savings programs. And you may see on TV Joe Namath talking about getting your money back or getting your benefits, or you may see folks talking about getting your 164 back. Well, that is a true thing. And Medicare savings programs have different levels. But one level is called SLMB. And SLMB will pay your Part B premium so that you do not have to pay that anymore and will help you. It's income-based. That's also something we can explore if need be. Part B also has an annual deductible. It's also weird. So the first one with Medicare A, it recurs, which is strange. But Medicare Part B's deductible, it's just one time a year, which is normal, but it's very small. Folks are used to larger deductibles. But next year it's going to be $240. This year it was $226. After that Part B deductible is satisfied, Medicare pays 80%, you'll pay 20%. So that's a co-insurance, right? And so again, we've talked about a few scenarios where a co-insurance could be not a big deal, and some where it could be a big deal. So potentially, that can be a very large gap in your health care, depending upon what procedures or what you're having done, or what type of doctor you're seeing. A few things that Medicare Part B covers. So mental health services, your preventative services, home health care after the 100 days in the hospital or skilled nursing, your outpatient care, your doctor and specialist visits, and then durable medical equipment, things like CPAP machines or wheelchairs or oxygen. That's handled under Part B as well. Part B also will handle some medications called Part B drugs. Typically, those are things that are going to be administered to you at the doctor's office or an infusion center. Sometimes medications like Prolia or Humira are done in that regard. And as opposed to it being billed to your Part D, where you get it at the prescription at the pharmacy, you'll get it at the hospital or the doctor's office. So I like to spend a little bit of time talking about things that Medicare does not cover as well. Because sometimes these are things that can help make a determination on what type of pathway of care is most important to you. So original Medicare, Part A and Part B, will not cover most dental care or dentures. Now, I have had a gentleman in the past who had a horse farm, and he had an accident, unfortunately, and was kicked in the face. Obviously, there was a lot of damage done and some reconstruction, and he had to go to the hospital. At the hospital, the Medicare covered the stabilization of the teeth that were broken out of his mouth and the bleeding that was in there, but the reconstructive surgery for partials or dentures, Medicare does not cover that. Medicare does cover eye exams related to diabetic eye care, cataracts, and glaucoma, and some medically necessary procedures as well, but not typical eye exams. So your year-to-year checkups, it will not cover that. And it won't cover anything as it relates to your eyeglasses. So that's important as well. Medicare Part B will let you go see your audiologist, and it'll pay for that. It'll let you go see your ENT. it'll pay for that. But as it relates to hearing aids, or the fitting of those hearing aids, Medicare does not cover that. So that's important to remember as well. Medicare looks at things that are considered non-essential or non-necessary treatments as something that you would have to be responsible for. So things like acupuncture, massage therapy, cosmetic surgery, those things are things that Medicare will not cover, but you would be responsible for. Now, in some circumstances, cosmetic surgery is medically necessary, and so those circumstances are on a one-by-one basis, and some things will be covered. But for, if you want to just, raise the wrinkles a little bit, Medicare's not going to handle that. The two big things that we need to be mindful of that Medicare does not cover. One, long-term care. Long-term care is an enormous gap in our health care today in America. And without a standalone long-term care plan, which can be very costly and very difficult to enroll into, or being able to self-fund long-term care, there are some very significant healthcare situations and financial situations you may find yourself in to have to spend down for additional Medicaid coverage for long-term care. So that's important to talk to your financial planners about. That's important to talk to Medicare consultants like myself about, to be able to prepare for that, because I've seen some very serious situations as it relates to having to spend down for long-term care services. Medications. So that's a big one I have to mention. Medicare Part A and B, other than the Part B drugs that I mentioned, will not cover anything that you get at the pharmacy. So your typical maintenance medications and your month-to-months, those are things that Medicare does not cover. So if we have just Medicare by itself, you'll have to have a prescription drug plan of some sort in place. So let's talk about the dreaded prescription drug Part D plans. This is the one that I typically get the most questions about, and it's the one that may have the most confusion, and it's because it's not quite as standardized. If you remember before, I mentioned that Medicare Part A and Part B are the same for everyone, right? Whether you're in Nome, Alaska, or Tallahassee, Florida, or anywhere in between. Part D is not like that. Part D is handled by insurance companies, and there are many various and sundry plans available, even in each insurance company. In any region. Your monthly premium on those is going to vary by plan. It may have an annual deductible, it may not. And it can also be adapted by the IRMA, the Income-Related Monthly Adjustment Amount. So if you fall into one of those categories, an additional amount will be added to your Medicare Part D premium. So drug plans have different costs, and that's based upon their formula. Does anyone know what formulary means? Have you heard that word before in the past? So a formulary is a compilation of medications that an insurance company will allow on their plan, and it'll have different tiers for those medications. You've probably heard the terms of tier 1, 2, 3, etc. And as you go up in tiers, it becomes more costly as it relates to copays. And each prescription drug plan, even within the same carrier, for example, the same insurance company, each different one may have a different formulary or handle medications on different tiers. So, of all things when it comes to Medicare, do not blindfold yourself and throw a dart at the board of drug plans, because that doesn't mean that you're going to get one that works for your medications. And I'll give you an example. I had a lady one time, and she took a very expensive medication for multiple sclerosis, $106,000 a year medication. And she knew this, and prior to her getting on Medicare, she was given a subsidy by her pharmaceutical company, and it was covered in full, and that was great. It was fantastic. But they changed their requirements when she got to 65. When she got to 65, we had to apply for extra help, or LIS, through the Social Security Administration. If she received extra help, then they would pay 50% of the cost of that medication, but she would still be responsible for the other half, which was well over $4,000 and not really doable. Now, luckily, in her situation, she did qualify, and it covered the medication almost in full. She paid roughly $10 a month for the medication. But let's back that up a little bit and say that she didn't know that she was going to be prescribed that medication prior to coming to see me. But when she did come to see me, she said, you know, I really just want to pay a little bit more for my drug plan, just in case. just in case something does get prescribed to me in the coming year that I'm just not aware of, and it may be high dollar. Well, if she had done that, there's one specific drug plan that I probably would have focused on because it has a very expansive formulary and covers medications very well. But guess the one medication it doesn't cover? The one that she took. And so there was no way in that circumstance, if we don't know what the medication is, it's very difficult to just assume and throw a dart at the board. Because then she would have paid a much higher premium for what she had until she was prescribed that, and then we still couldn't have changed it at the time anyway. We would have had to wait until this time of year in the annual enrollment period. So it's very important to sit down, do the research on your prescription drug plan, and make a very solid decision on that when you initially do it. Because for all intents and purposes, when you lock that in then, it's not going to be able to be changed until this time of year for a January 1 start date. Okay? There are two ways to get a drug plan. One is a standalone prescription drug plan. The other is through a Medicare Advantage plan with prescription drugs. So there are two different types of Advantage plans. It's death by acronym here, so it's MAPD, right? Medicare Advantage Prescription Drug, or the other type of Advantage plan is just MA, and you can probably guess that that's just Medicare Advantage, right? So I've done this presentation many times, and everybody always has bad stories about the donut hole, the horror stories about that. It's no fun, so I decided that I would look and find a fun slide at least, and then we can look at while we talk about the donut hole. So a few things that, in my experience, we come across that folks misunderstand the donut hole. A lot of people I'll have call and they'll say, gosh, I hate XYZ drug plan because XYZ drug plan gets me in that donut hole in June. Well, it's not the drug plan, unfortunately. The donut hole is a glove, and it goes over all prescription drug plans and Advantage plans that have prescription drug coverage. So if you go into the donut hole, I hate to say, it's not going to matter which plan you have. It's going to happen within the same month or maybe the month right after or before on any of the plans. But the coverage phase is not determined by medications retail. It's determined by the medication's retail costs, not just what you pay. That's the other misconception I get. So I'll have people call in the middle of the year and they'll say, gosh, Bobby, there is no way I've paid $4,000 in co-pays. I can't be in the donut hole yet. Well, it's not just what you pay. It's the entire cost of the medication that goes to that. So for example, let's assume that you have a medication and its full retail cost is $1,000. But you only pay $50 when you go get it at the pharmacy. Well, that full $1,000 goes to getting you into the donut hole or through the initial coverage phase, not just the $50. So if you have a number of medications that are fairly expensive, the retail cost is what will accumulate to then get you into the donut hole. All drug plans will perform differently based on your specific medications. I know I said this a minute ago, but I'm going to reiterate myself. Because I know everybody in here, I usually ask this question, and I'll go ahead and do it now. If you know someone who has a feeling about an Medicare insurance plan or Medicare insurance company, good, bad, ugly, or otherwise, raise your hand. They've shared it with you, right? You've got somebody at church or somebody that's a family member or a buddy or a neighbor or somebody. Everybody that's been on it has a feeling about something. And so I see a lot of folks who will listen to their friends family members, and they'll say, gosh, I just enrolled into this one because so-and-so really liked it and it worked great for them. Well, that's good. It worked great for them, but it may not work well for you because it's based on your specific medications. Here's one that's important as well. You may be used to, with your group plans or marketplace plans, your drug co-pays going towards your maximum out-of-pocket. You guys familiar with the term maximum out-of-pocket? So it's a catastrophic protection, right? It's like a bucket. At the beginning of the year, the bucket's empty. Let's write maximum out-of-pocket on it. And as you go through the year, you pay a copay or a co-insurance when you have a procedure done, or you see a doctor, and you throw that copay or co-insurance money in there. If at any point through the year the bucket fills up, well, you have free health care after that. You don't have to pay anymore, right? So there's a difference between how medications are handled on group and marketplace and private insurance, and Medicare Part D. Your copays are not calculated into your out-of-pocket maximums on Advantage plans, and it's not calculated into your Part B deductible, if you remember before, the $240. So just be mindful of that. Part D lives in Part D world. It doesn't mix into the medical aspect of Medicare. So if we looked at these initial coverage phases, this year, $4,660 of the retail cost is what got you into the sad bite of the donut, the one that has a hole in it. Once you're in the sad bite of the donut, you pay 25% of the retail cost of the medication. So that's why, if you have been on Medicare and you've seen your costs go up at a specific time, that's why that happens. So for example, the medication that we talked about before that was $1,000. In the initial coverage phase, you were paying a $50 copay for it. The insurance company was paying $950. Well, now we've made our way into the donut hole. Now you pay $250 for it as opposed to the $50 because you're paying 25% of the retail cost. So that's why some folks, at some point in the year, you go, whoa, why is that so much more expensive? And that's why. So now you're into 25% of retail cost. Now, this year, if you made it to $7,400 of retail cost, you made yourself into catastrophic coverage. So for the remainder of this year, catastrophic coverage, if you happen to be in that at this point, or you find yourself in it next month or the month after, you'll pay the greater of 5% of the retail cost, or $415 for generics, or $1035 for brand name medications. Now, it's about to get fun. So let's talk about this. Next year, because we're close enough, I haven't put that on this slide yet because I still have a few more presentations this year to do. Next year, this changes just a bit. The Inflation Reduction Act has changed the way that Medicare and prescription drugs are handled. A few things that you may have seen already this year came into play. Insulins are capped at $35. So if you have insulins, you may have seen that. And that's a great benefit because they were extremely expensive before. But next year, your initial coverage phase, as opposed to $4,600, is going to be $5,030, and your catastrophic is going to be $8,000. But next year, catastrophic is a true catastrophic. So it's going to be handled as a maximum out of pocket. So if you do happen to find yourself in the catastrophic phase next year, you will have free medication for the rest of the year. You won't pay any copays on it. So that's a great benefit. In 25, the government takes the first bite of the donut and everybody starts in the donut hole at 25% of retail cost in 25. Up to a $2,000 out-of-pocket maximum. So in 2025, you'll start out at a 25% of retail cost charge for your medications, but if you ever at any point throughout the year pay $2,000 in copays, you'll have free meds for the rest of the year. So be mindful of that. As changes happen, I do highly recommend that you do have, in the next couple of years, conversations around this time of year as it relates to drug plans, because they are going to be changing fairly drastically. So you may already know that I like to give examples. So I made up a gentleman called Medicare Mike, and he makes bad decisions. One of the most important things that I want to talk about is protecting you from penalties. Because for all intents and purposes, penalties stay in perpetuity. They're going to stick around with you forever if you find yourself in that situation. So one way to protect yourself from penalties is to have creditable coverage. So if anybody's writing down notes, that's a good thing to write down. Creditable coverage. Some of you may already be on Medicare, and it may not be that big of a deal at this point, but if you were upcoming to Medicare, creditable coverage is an important term to remember. There are a few things that will give you creditable coverage. Group insurance will give you creditable coverage, but not COBRA. So remember that. A lot of folks will think just because it's still group coverage and you're just paying the full premium for it, that it's still creditable. It is not. COBRA is not creditable coverage. Private insurance, like through an insurance carrier, is not creditable, and marketplace coverage is not available, because when you turn 65, you have to choose to take Medicare as opposed to marketplace. So those are things to be mindful of. So if you don't get Part B when you're first eligible, your monthly premium will go up 10% for each 12-month period in which you should have had Part B and did not. And in most cases, you pay that premium addition for as long as you have Part B. And the penalty will increase the longer you go without Part B coverage. Now, this is not prorated within a year. So if you go to, let's say it's January, you're supposed to have your Part B, and you go from January to June, it will not assess a penalty. But if you go January to January, you will have a 10% penalty on top. If you go to the next January, again, and so on and so forth. So the Part B penalty is 10% on your standard Part B premium for every 12-month period in which you were not enrolled. It should be. And it is permanent unless you qualify for a Medicare savings program. If you remember before, I mentioned those. Those are income-based programs that will pay their own penalties. The federal government's not going to pay their own penalty, right? So they will pay that for you if you find yourself qualifying for a Medicare savings program. So Medicare Mike here that makes poor decisions. Medicare Mike in this circumstance is 72. He chose not to enroll in Medicare Part B when he aged out and retired at 67. His group coverage ended upon his retirement, and it left him without creditable coverage. At that time, he was in great health. He knew that he had Medicare A to cover any health concerns that involved a hospital visit. However, unfortunately, Mike now has been diagnosed with type 2 diabetes, and he has to visit his doctor quarterly, as well as several specialists that help him control his blood sugar. So now, as you can imagine, Mike sees a reason for Part B coverage because that handles doctor visits, right? He's seen a lot of doctors. And he's decided now he wants to opt into his original Medicare Part B plan. But due to his choice to bypass enrollment at 67, he now has to pay a penalty of $82.45, which is added on top of his standard Part B premium of $164.90. Now his combined Part B premium with penalty is now $247.35, which he's required to pay in perpetuity. So that's something that you can't just, it's good intentions. Good intentions won't protect you. That's one way to put it. So if you don't enroll in the Part B when you're first eligible, you have to wait till the open enrollment period, which is January 1 through March 31st. So if you call me up in the middle of the year and you say, "Oh, you told me not to miss up and enroll, but I forgot, Bobby. It's June. Can I go ahead and enroll?" You can't enroll. Good intentions won't protect you, so you will continue to accrue penalty if you are accruing one until January 1st, when we can get you enrolled into Part B. Medicare Mike made another poor decision. So there's another penalty that you can accrue, and that is for Part D. This is the one you see most frequently. Because a lot of people think, I don't take any medications, so why do I need a Part D plan, right? That's common sense. I'm not hungry for the cheeseburger, why would I order a cheeseburger? Well, that's the way that we think, but unfortunately, that's not the way that the federal government has this set up. So you have to have a Part D plan regardless of taking medication or not. And the late enrollment penalty for Part D will happen at any time after your initial enrollment period that you go 63 days or more without a creditable prescription drug plan. Now remember, creditable coverage is very important. So that's group coverage, or in this case, for Part D, it could be VA coverage if you have coverage through the Veterans Association for serving in the military. Typically, this is going to last as long as you have Medicare as well. And this penalty, I would say, is even more detrimental because it's 1% of the national average. This year, that's roughly $33. But it compounds monthly. So for every month, that 33 cents roughly that goes there just continues to compound upon itself until you do get a creditable prescription drug plan. At which point it would stop, but then it would allocate the remainder of that penalty on top of whatever prescription drug plan premium is best suited for your medication needs. So that could be great or small, depending upon what you need. If you qualify for LIS, which is Low Income Subsidy through the Social Security Administration, That will do away with your Part D penalty. And if you qualify for a Medicare Savings Program, you'll qualify for LIS as well, and that also does away with your Part D penalty. So in this story, Medicare Mike is 75. Until now, he's taken no medications, and he assumed, as most would, that since he took none from age 65 until now, he wouldn't be required to enroll in a prescription drug plan. Unfortunately, now Mike has been diagnosed with a condition, and it requires several medications that, without the help of insurance, are extremely costly, and he's decided now to enroll into a Part D plan, a prescription drug plan that meets his individual prescription drug needs. But now he has to pay an additional $40.10 combined with his monthly premium on the prescription drug plan that fits his needs, and that's going to go on forever unless he qualifies for a Medicare Savings Program or LIS. Again, good intentions don't protect you. So if you don't enroll into Part D when first eligible, you'll be required to wait until the annual enrollment period. Here's another acronym, AEP. And that's right now. It's the frenzy, right? So it's October 15th through December 7th. That's when everybody can make a change to their prescription drug plan. And please note, this is the only time you can make a change to a standalone prescription drug plan. You cannot do that in OEP. And for all intents and purposes, you're not going to be able to do it throughout the year either. So right now is the time that you can change a prescription drug plan standalone. But even if you call me again in the middle of the year and you say, ooh, I forgot. Sorry, Bobby, I know you told me not to. We can make a plan of action. I can maybe try to help mitigate some medication costs through different means, but until now, we can't do anything. And it won't start until January the 1st. And let's say it's June, you called me, that penalty is going to accrue month to month from then until January 1st, even though we enroll you in the AEP period. So be mindful of that. I don't want anybody to ever get a penalty that I talk with. If you have additional questions about penalties, by all means, please ask, because those are things, with all of us being on fixed incomes and all of us, all the costs of things going up, every bit counts, and I don't want anybody to have to deal with penalties forever. All right, here's the fun part of the conversation. So let's talk about choosing a path. Choosing a path is as individual as it can possibly be. There's two different types of Medicare plans that go along with or instead of your Medicare, A and B. And they perform drastically differently. So I want to make a good foundation of education on these two so you can make a good educated decision on which one fits your specific healthcare needs the most. Choices on how you choose one of these pathways include everything. Whatever goes into the ingredient list of your medical history, your medical needs, or your retirement wants, needs, or budgets, all of that goes into factoring which type of plan or pathway you choose. But regardless of which pathway you choose, you have to start at the fork in the road with original Medicare A and original Medicare B. Either way, you've got to have A and B before we take a choice of pathway. Okay? So let's assume we've got our Medicare A and B, and let's go down pathway 1. Pathway 1 is what you're probably not as familiar with when it comes to insurance and the way it performs. Medicare supplements, or you may have heard them called Medigap plans, because they plug the gaps in Medicare. You remember what gaps are, right? Your financial responsibilities. They're going to vary. There are typically 3 plans in our region that people enroll into, and really just 1 or 2. But the big difference between what you're used to with healthcare and what Medicare supplements do, or is they do away with network. So who knows what network means? That means your doctors have to choose the plan, right? Or be part of that plan for you to go and use the insurance there. That's how group insurance typically is. That's how marketplace insurance is. So Medicare supplements aren't like that. Medicare supplements are called portable. And portable means that you can take it to literally any doctor in the country that takes Medicare, and they can't turn you down. It can be Bozo the Clown's Plan G, and they have to take it. It can be the most obscure carrier that you've never ever heard of. Okay? So that's drastically different than what you guys are used to. You're used to having to make sure your doctor accepts the plan. So as long as the doctor accepts Medicare, any Medicare supplement will do. Also, Medicare supplements are uniform, cookie cutter the same within plan letter. So a Plan G, for example, matches with Medicare, A and B, and every Plan G is identical. There's not a better one. So you might say, if they all are exactly the same and identical, and every doctor takes them, well, how do you choose one, right? They're all the same. If the cheeseburgers are both equally delicious, which one do you grab? Well, you want to grab the one, obviously, that has the most competitive cost. But more importantly, you want the cost to remain as stable for as long a period of time as possible. Because all Medicare supplements will go up in cost periodically, but the federal government doesn't regulate that. The insurance carriers can choose to raise their rates as they see fit. So historically speaking, you want to be able to look back and see what that historic premium increase is over the course of time and choose the carrier in your region which has the least fluctuation in cost. Does that make sense? Getting deep into the math. So here's another thing that is a little different when it comes to Medicare supplements. We mentioned the Plan G a moment ago, and this is the easiest one to outline. So everyone here is used to co-pays and co-insurances with your group insurance and marketplace or what have you. But supplements are typically not like that. A Plan G, for example, the only thing that you would pay out of pocket, other than your premium monthly, would be the Part B deductible. Does anybody remember what that was for next year? I won't call you that. $240 next year, $226 this year. So for easy math, let's say on January the 1st you went to the doctor and it cost exactly $240. Got the check, gave them the $240, and then literally every day after that of the year you could go to the hospital, the doctor, have a procedure done, and you would pay nothing else. No co-pays, no co-insurances, just your premium. So that's drastically different too, is it not, than what folks are used to. With a Medicare supplement plan, Medicare supplements only supplement Medicare A and B. So we looked at the things that Medicare A and B do not cover earlier in our conversation. So, what's the biggest thing that we have to get to avoid penalties? Drug plan, right? So you got to have a standalone drug plan, regardless of if you take medication or not. Then if you need or want dental coverage, or vision coverage, or hearing coverage, you have to have standalone plans there. So as it relates to Pathway 1 in a Medicare supplement, you get a good bit of flexibility. But you will pay more upfront premiums, but less on the back end, typically speaking, because no co-pays and co-insurances. A few things the Medicare supplements cover. One important thing is that they do not need referrals. If your big toe hurts, go to the podiatrist. As long as the podiatrist doesn't need a referral, some specialists prefer having referrals. But as long as the specialist doesn't need a referral, get your big toe checked out. They'll fix it. No network restrictions. We talked about that. So as long as they take Medicare, you can be anywhere. Covers the Part A costs and co-insurances. Covers primary care and specialist visits. Several plan options. And outpatient care. All right, let's walk back up to the mouth of the fork in the road. We've got our A and our B. Now let's go down Pathway 2. Pathway 2 is what you're more used to, and what you see tons of stuff on TV for, and get tons of stuff in the mail about, right? These are Advantage plans. I once had a gentleman I sat down with, and I said, just tongue-in-cheek, I said, you know, you'll have enough of this stuff in the mail to kindle in your fire for the winter. And a year or so later, he called me back to come out and review with him, and he said, I did what you told me to, and I didn't remember what I told him to do, so I was like, oh, hold on, what did I tell you to do? And he said, I kept it all. I said, oh, yeah, I remember now. I said, well, you got my attention. How much did you actually accumulate over the course of the year? He said, I have 2 contractor bags full of junk from the mail. I said, well, you certainly can when you're fire bill winner, can't you? Well, Advantage plans are network-based. So HMOs, PPOs, HMO POSs, and just a brief overview of those things. HMO means, in the most simplest of terms, you got to go to the doctor that takes your plan. That's it. Can't go out of network. PPO means that you really ought to go to the doctor that takes your plans, but you could potentially go out of network, but you'll pay more. And HMO POS means that you really need to go to the doctors in network, but you could go to the doctors out of network and pay full price, but the full price will go to your out-of-pocket maximum. There's a test on this. Medicare Advantage plans are often called one-stop shops. They have your hospitalization, they have your doctors and specialists and outpatient care, they have your prescription drug plan, dental, vision, hearing, all that built into one happy little card, right? They also have some extras. I'm sure some of you have heard of Silver Sneakers, gym membership. Most of them will have a gym membership that's available to them. The thing that folks like the most these days that I find is the over-the-counter benefit. Over-the-counter benefit is basically free money that they'll give you that you can use to get your Pepto-Bismol and your Tylenol and your Band-Aids and compression socks and adult diapers and things like that that you get at the pharmacy that you have to have, but you grab on the way to get your medications off the shelf, right? Some will have transportation benefits to help you get to and from doctors or the pharmacy or the specialist if you need. But what you will find is that depending upon plan and carrier, and each carrier will have a number of plans in our region, you will have some co-pays, you will have some co-insurances, you will have maximum out-of-pockets, and those things are going to vary by plan. The plans will have a range of premiums. Some are $0. Some are in the $20 to $35, $45 range. Some are in the $50 to $70, and a few in the $100 range in our region. And as you can imagine, as you go up in cost, those will offer more robust benefits. You might ask as well, you can't get something for nothing, right? So how's it $0? Come on, Bobby. How's it $0? I'll tell you. So the reason that it's $0 is that all the years that you worked for your Medicare Part A that you paid into it, the federal government has some coffers of money set aside to pay for your Medicare Part A. And then you pay that Medicare Part B premium, right, every month. So if you choose to be on Pathway 1 with a supplement, Medicare is your primary insurer and the supplement is your secondary insurer. But if you choose Pathway 2, Medicare is no longer your primary insurer, and for all intents and purposes, really doesn't insure you much at all. The Advantage plan now is your sole insurer, and then the federal government gives $1,200 to $1,400 a month to whichever insurance carrier you've chosen. So that $1,200 to $1,400 of your money that you put away from your working years and your Part B premium, that pays for those base level plans in full. Right? And then as you go up, it needs a little bit of premium for additional benefit. But that's how it's $0. It's not that you're getting something for nothing. You're actually paying for it. You're just not cutting a check. Medicare Advantage plans are important in region, but different in group and marketplace. You may be used to your group plan or your marketplace plan. The farther you get away from your regional bullseye, having difficulty finding doctors in network. It's not so much that way with Advantage plans. Most Advantage plans, especially the larger carriers, will have national networks now, which means that if you're in Nome, Alaska, and you need to see a cardiologist, then they'll honor your specifications for the region as long as they take that carrier's plans. Now, be mindful that regardless of plan, so if it's a supplement or an Advantage plan, you will always have emergency coverage. It's never going to be out of network. So that's important to remember. So if you're traveling, you're going to be just fine on either type of plan. So here are a few things that Advantage plans cover. Doctor visits and hospital stays, preventative services, your drug plan's built in, routine vision, dental, and hearing coverage. It limits your out-of-pocket costs. So if you remember, in contrast with Pathway 1, where it almost does away with all out-of-pocket costs outside of a premium, the Advantage plans will limit your out-of-pocket costs. And they all have a maximum out-of-pocket. So that protects you from catastrophic situations. So, more acronyms, right? Let's talk about these. So some folks I know are already on Medicare and are here for some additional education. Some people are upcoming to Medicare. So this first one is very important, the IEP, or Initial Enrollment Period. So you have 7 months surrounding your birth month to enroll into Medicare. 3 months prior, the month of, and 3 months after. Now Medicare will always start on the first day of a month. So who ventures to guess when your Medicare would start if your birthday is on the first day of a month? It starts the first of the month prior. The annual enrollment period is what we're doing right now. So the annual enrollment period is October 15th through December 7th. This is when you can make changes to your medical plans, so Medicare Advantage plans or prescription drug coverage. And remember that, because drug coverage is the only time you can do that. Open enrollment's upcoming. So that's when you can change Advantage plans, not drug plans, or switch back to original Medicare. And that's January 1st through March 31st. That's also when you can enroll in Part B if you've forgotten to, even though I told you not to. And then special enrollment periods. These are ones that you typically can't control. Special enrollment periods come and go, and they are sometimes qualifying events, but a lot of times they're things you have nothing to do with, like a doctor passing away or going out of network. When you move, FEMA has one. In Sevierville, they had fires the last couple of years, and in certain counties and zip codes, they allowed a FEMA special enrollment period. Some Advantage plans have 5 stars. I haven't seen drug plans have 5 stars around here, but if a drug plan or an Advantage plan has 5 stars, it's very special. The Center for Medicare and Medicaid Services allocate that. That gives you a yearly special enrollment period. So the big thing around special enrollment periods is if you have a problem or a question, if something's not working, just call. Because you're not going to know the reasons or the opportunities as well as someone who is a Medicare consultant will. And so we may be able to fix something that you may not think is even an opportunity at the time. Okay? How we enroll in Medicare A and B. If you're currently on Social Security, so if you were disabled, as we talked about before, you'll wake up one morning about 3.5 months prior to your 65th birthday, and there'll be a shiny new red, white, blue card in your mail. You won't have to do anything. That's the easy way, right? If you have ALS, your Social Security disability will begin, and it will start the same month. And if you're disabled after your 24 months, it will start on the 25th. If you were to enroll on your own, the most efficient way to do this is to have a My Social Security account on SSA.gov, and either a Medicare consultant, a professional, can help you do that. You can do it yourself, or you can call the local Social Security office and they can do it for you as well. If you work for the railroad, call the railroad. The railroad actually handles their own Medicare, so they handle it. It's the same Medicare A and B, it just goes through them instead of Social Security, so I would suggest calling them. They handle it slightly differently. If you're already on Part A and you need to add Part B, this happens a lot. Folks are working past 65 a good bit. Oftentimes they stay on group insurance. I would suggest doing a cost versus benefit analysis if you're doing that. Oftentimes Medicare is going to be less costly and certainly better coverage than group insurance. But if you have chosen to stay after age 65, there's a couple of forms that you have to fill out. One by your benefits folks to show creditable coverage, right? And then the other is your Part B application because you've already got Part A. That will go physically down to the local Social Security office. And then again, if you're diagnosed with ESRD or end-stage renal disease, you can go online through My Social Security account and sign up as well. So finally, just so you are aware, I am always happy to help anybody that I know. This is how I do things. I'm not a salesperson. I'm a Medicare benefit consultant. And as a Medicare benefit consultant, I can help you enroll into Medicare and Social Security. I can give you individualized consultation based on your specific healthcare needs. I can help educate or dive deeper into pathway education and selection. We can explore the income-related adjustment or income-related programs that we discussed briefly earlier. And I can help you enroll into your pathway when you make that determination of which is best suited to your specific healthcare needs. Also, the company that I work with, our administrative staff and myself are there for lifetime policy and support. So I often tell people, don't feel like you're on an island. That's what I'm here for, and don't call 800 numbers. I'll call them for you. So, I appreciate you guys very much today, and I really hope that this has been helpful to you. If you need anything or have questions, I'm happy to answer as many as we are. Ms. Teresa, you tell me what to do, and we'll go from there. Thank you.